All right, we're back live. This is Senate Health and Welfare. We're moving to S 25, our PFAS or chemical bill that we've been looking at that's come back to us from the House. We passed it last year at this time and then, or a long time, a month or so ago, last year. So now we're looking at the recommendations that have come to us from the House, and we have the AG with us. So thank you for being here.
Thank you for having me. And this isn't the first time I've testified on this bill in this committee. It seems like a lot has happened since then, but we're back. I continue to be very enthusiastic about this bill. I think I might have mentioned the first time I testified that I found this bill myself and was like, this bill, we want to support this bill. I was very excited about it. It has changed in several ways. The first that I want to highlight is it's been moved to Title IX, which is where the Consumer Protection Act is. I think that that's important and supportive of that change. It's also been expanded to incorporate existing PFAS bans and some additional ones. So cookware, incontinence and seed protection products, juvenile products. This also makes sense, and I'm supportive. And it contains what used to be S 197, which is like a working group to look at various issues in consultation with various actors, including my office. I'm enthusiastic about that as well. Just ticking through these regarding Title IX, one of the change, we were happy to take lead on providing guidance for businesses to help them comply and understand the law. We do that all the time with new laws. Or I should say all the time, because you don't pass all new laws that affect the Consumer Protection Act, but I would say regularly we do that. That's something we're happy to do. We don't just produce guidance, we answer calls and work with businesses to help them comply and understand the law. I should also note that we have a small business advocate. So to the extent that this impacts small businesses, we have in our office a small business advocate who is very knowledgeable, but also has easy networks with the small business community here in Vermont. And we also, of course, work well with our friends at the Vermont Department of Health, who is a client of my office, and ANR, who we work very closely with on a number of issues, including getting work from them too. So not a problem there. And regarding the implementation enforcement, so if it's in Title IX, which is where I think it should be, which is great. I wanted to note that I believe there's a change to make it clear that a violation of this is a violation of the Consumer Protection Act, and I would support that, so that that's clear. And also note that the Consumer Protection Act has within it rulemaking authority. So additional rulemaking authority, it's not needed because it's already in the Consumer Protection Act that we have rulemaking authority. So flagging that for you. And wanted to note, in case you didn't realize, we have about 8 or 10 lawyers in the consumer unit in my office, and pretty much all they do all day long is enforce the Consumer Protection Act. So we are the experts on the Consumer Protection Act. That's like what we do all day long. And this is an exciting bill to include in that work. The last comment I wanted to make is on the enforcement date. This is like a deal breaker, but I noticed that the enforcement date is a little later for lead products that might contain lead. And I flag that. I don't know that it's necessary. That's a really long way away. That's like 2 election cycles away. So who knows if I'll even be the person in the Attorney General's office to enforce this. And I would like to have the opportunity to help those who might find they have trace lead in their products understand the law and comply with the law. But I also would just note, I think it was 1978 that lead paint was banned, and it was, I think, also the 70s when gasoline. So, I mean, it's been like longer than some of us have been alive. So it just seems like one more year to make sure there's no lead in the product that doesn't need to have lead in it. Just seems like, I don't know that that's necessary, but I'll let others weigh in on that. I'm sure people have other.
I'm trying to find the date that you're talking.
It's the very last page of the bill.
The effective dates.
Yeah, the effective dates.
Oh.
Section 2 is in 2027 instead of 2026.
Okay. I'm sure, okay. Well, we'll look at that.
Yeah,
Okay,
just
like
for, is it
for
necessary? I
flagging
don't,
it.
I don't know. It's not like we're surprised that lead isn't good for you. It seems like it's been around for a
Yeah,
long
we've been
time.
working
no.
on lead for a long time.
Yeah, so I don't know why they need another year, but. And that's really all I had to say. I'm happy to answer questions, but you know, all in all, we're really excited about this. And I am, I just feel really strongly about, you know, our role protecting consumers and to have this helping the industry get in alignment with what's safe and appropriate for these products. I also just, I think Vermonters in general have a heightened sense of, you know, what's good for, you know, we're just a healthier state, we're a state that cares more about the environment. And I think this is what consumers really want, is to have the reassurance that the products they're purchasing don't have PFAS in them, don't have lead in them and these chemicals. So this feels really, really good. And it definitely, in my mind, aligns with the values that we have in Vermont and certainly the work that we do in my office.
Thank you. I do have one question for you, and I don't know whether you or someone else in your office can answer it. And then one of the questions that was brought up regarding lead in products, whether it's intentionally or not intentionally added, was labeling or a warning. Is that something that we can do?
You know, labeling, as I'm sure in your decades in the Senate you've encountered, is forced commercial speech, so there's a whole standard that needs to be met with that. I don't know, lead might have regulations already in place around it when it comes to labeling. I don't really know, off the top of my head. We can certainly look into that, or I can work with Katie, sorry, on this, if that's something that you want our help with.
But just to understand what is possible, I think, don't have to spend a lot of time on it. I do know we've had some real difficulties in the past.
Yeah,
Labeling and trying to do that, so.
yeah, you have to sort of thread a needle. I mean, obviously, like you said, the harms of lead are
Yeah.
well known, so that's helpful, but yeah, there would have to be careful thought put into that.
Okay. Thank you. Questions for the AG? We're good. Thank you.
Thank you.
For your good work in this area. I appreciate it.
My pleasure.
So we're going to move to Matt Chapman, who's here from AMR. Thank you for being here.
You're welcome.
And thanks for the work, the continuing work that you've been doing on the bill. I know S-197, you probably followed over into the House.
I did, yes, sir.
On that. So you have testimony, but I think one of the big questions for our decision making in here is on the level of lead that we're looking at in cosmetics. I mean, that's just where it all comes.
Sure, and so the way we normally try and separate functions between us and health is that they are really the ones who are the experts as it relates to lead and consumer products. It's sort of a shared function with PFAS, but I defer to them when it comes to lead and consumer products. So I can't speak to what the appropriate level might be with respect to that. I'm certainly happy to I'm happy to state that, you know, we've reviewed what's been done with respect to the other consumer products, cookware, incontinency products, and they're similar, if not identical to things that have been put in place in other jurisdictions. And I think that that's a very helpful thing as we move forward.
Okay.
Administering this.
That's good.
So,
Any thoughts on labeling?
you know, I think again, if the question around labeling, so I have not done any research into a labeling requirement associated with this. I think the other thing we would have to look at is that this is also regulated by the Food, Drug, and Cosmetics Act, which has specific requirements around what can and can't happen with these types of things. So that, and again, not flagging it that it's a thing that we need to look into, not.
And they also look at lead levels, so.
Right.
Yeah. So is there anything you would like to share with us on S-25?
No, I mean, I think that, I guess I would say that the changes and the additions in the work that's been done on regulating PFAS and consumer products is incredibly helpful. It's consistent with the goals of ANR and the Department of Health as far as things we're trying to accomplish And we're very supportive of the study because I think it will allow us to come back to you with hopefully a more comprehensive and broader approach.
Yay,
So,
good.
And that's the study we put in a different bill in the House.
197.
Yeah, 197,
That's,
yeah.
that says
So it's
197.
they've been merged in
You'll
the
like
house.
So we have two bills at once. Yeah, it's called S 197. That many bills in the world. Okay, any questions for Matt? I thought it would be important to bring you back since we had worked with you so hard on 197. and
Well, and I
other
appreciate it.
things. So,
So,
thank you.
all right, thank you very much.
So we also have with us, now we can move to our discussion and concern regarding lead in supply chain and then talk about lead levels in products. So we have with us Dr. Eaton from University of Washington Grad School. So Dr. Eaton, why don't you introduce yourself for the record? And thank you for your patience, first of all, and then thank you for being here.
Well, sure. Thank you. My name is David Eaton. I am a retired professor emeritus from the University of Washington, where I spent 40 years on the faculty there. And I've spent most of my life looking at how toxic chemicals affect human health. My appointment was in the Department of Environmental and Occupational Health Sciences in the School of Public Health at the University of Washington. And I currently hold an appointment as an adjunct professor in the School of Pharmacy or the College of Pharmacy at the University of Arizona. And I believe Dr. Stanton Ms. Stanton may have some additional comments in terms of how I became involved in this. So I will stop there.
Yeah, thanks, Dr. Eaton. Yes, we have known for a long time about the unavoidable and unintentional contaminant of lead in products, consumer products, all products. And what we wanted to do first, good morning, and thanks for having us here. You know, thanks to the Welfare Chair Jenny Lyons and Vice Chair Weeks and the rest of the committee. Before we actually want to get into the comments, a little bit more on Dr. Eaton and myself. So happy to do a little more introduction to Dr. Eaton. Very impressive CV, as you saw. It sounds like we've already highlighted that he is, he had positions as a professor in environmental and occupational health sciences at Washington. He's currently an adjunct professor of pharmacology and toxicology at the College of Pharmacy at the University of Arizona. He has decades of experience, numerous honors, awards, fellowships, including this year's Society of Toxicology Merit Award. He's served on various scientific advisory boards and panels as both chair panelist, including those for the National Academy of Sciences, Engineering and Medicine, the National Research Council. He's also served as an advisor to the National Institutes of Health, National Centers for Toxicogenomics, National Institute of Environmental Health Sciences, and the National Toxicology Program. What we're hoping that Dr. Eaton will deliver is his expert views on lead exposure, risk, and the potential public health consequences of lowering the current federal guideline level from 10 parts per million. I then will discuss the regulatory landscape, including what the U.S. Food and Drug Administration's guides and specifications for lead in cosmetic products and their ingredients are, including colorants. So with that, I will send it back to Dr. Eaton.
Well, thank you, Ms. Stanton, for that introduction. And I'd like to thank this committee for giving me the opportunity to share my expertise and perspectives on the potential implications of lead in cosmetics. In my retirement, I've been focusing on how the science of toxicology and environmental risk assessment can be used effectively to address important environmental health risks from public exposure to toxic chemicals. Any risk assessment requires the use of basic principles of toxicology and risk assessment to help regulators distinguish public health risks that are significant from those that are not. This often involves helping to distinguish between risk, which is the probability that an outcome will occur, from hazard, which is the potential. And certainly there is potential hazard with lead, and as there is with almost any substance. So the issue at hand is, does the presence of low parts per million levels of lead in cosmetics or personal care products present a potentially significant public health risk? And will lowering the concentration of lead in such products below 10 parts per million help to reduce that risk? So for lead, the public health focus is almost exclusively on incidental exposure of lead to small children that results from exposure to contaminated soil, outdoor soil, house dust, or in some instances, contamination of lead-containing toys or lead-contaminated food or drinking water. For several well-characterized biological reasons, young children are much more susceptible to the adverse effects of lead than adults. So that's why when we do risk assessment with lead, we focus on children. If you protect children, you will also protect adults. The question then becomes, does the presence of trace amounts of lead in cosmetics, say 10 parts per million, the current federal limit, contribute significantly to overall childhood lead exposure from other common sources of lead in the environment? So to address this question, I did a fairly detailed, what we call a site-specific, or in this situation, this circumstance, a situation-specific risk assessment to determine the potential level of exposure and thus the level of risk of lead in cosmetics using well-accepted standardized approaches to risk assessment. So the hazard, which is the potential to cause harm for lead, is well known, but the risk requires an estimate of dose, how much and how often. So I did a risk assessment of cosmetics, of lead in cosmetics, and I assumed that all of the cosmetic that might be used contains 10 parts per million of lead. Most of them will have less, but I've assumed the worst case of 10 parts per million, which is the current level of federal level. In order to assess risk, one has to assess the potential for exposure in the pathways or routes of exposure. The most obvious pathway of exposure one might think about with cosmetics would be dermal exposure, that is, that direct application to the skin and then absorption across the skin. Now, fortunately, for the type of lead that is present in cosmetics that comes from natural clays and soils, it's been well established over decades of research that the absorption of lead across the skin of children or adults is exceedingly small. And basically all of the risk assessments that EPA has done looking at lead exposure in children in areas where lead has contaminated soil have concluded that dermal exposure does not really contribute significantly to overall exposure. However, dermal exposure can lead, especially in children, to what we refer to as hand-to-mouth contact. So the exposure on the skin can in fact result in exposure, but it's usually secondary to a child touching the material of a toy or a mother's face in the case of cosmetics, and thus having some hand-to-mouth contact. Excuse me. Inhalation exposure in this situation is also really not important. If one goes through calculations and looks at dust that might be generated from applying a powder, for example, the exposures in the time frame of that is exceedingly small and does not contribute significantly. So this really leaves us with the most common pathway of exposure of lead to children, which is secondary to hand-to-mouth contact, and thus it's oral exposure. So then the question becomes, how much cosmetic could reasonably be ingested by a small child? Based on decades of research on lead exposure to children from lead-contaminated house dust and soil, the EPA, the FDA, and other regulatory agencies have developed really sophisticated science-based models that allow one to reasonably estimate how much ingestion of lead is associated with an increase in the level of lead in blood. That is what's important, the so-called blood lead level, which is really the gold standard in determining whether excessive exposure of a child to lead has occurred. And these models that have been developed over decades indicate that a small child exposed to 1/1,000,000th of a gram or 1 microgram of lead on a daily basis over the period of weeks, months, and years would have an increase in their blood lead level, this measurement that we use to determine excessive exposure, the blood lead level of about 0.16 micrograms per deciliter. Again, that's exposure to 1 microgram for a small child on a daily basis. Now, to put that number in context, that 0.16 micrograms per deciliter increase in blood lead, the typical background level of lead in U.S. children in 2021, determined by the National Health and Nutrition Examination Survey, something the CDC does, is about 0.6 micrograms per deciliter. Now, it used to be typically 5 to 10 or even more than 10, and we've made amazing progress in reducing childhood exposure to lead over the past several decades. Now, this 0.6 micrograms per day or micrograms per deciliter, a typical blood lead level in a child in the United States, is the result of daily exposures of lead from the diet, drinking water, house dust, etc. And it's consistent with estimates of the EPA and FDA that typical childhood exposure today of lead is probably around 3 to 5 micrograms per day for a young child. And again, that would result in the background levels that we see of around 0.6 micrograms per deciliter. Now, how does that relate to lead in cosmetics? So I did what we refer to oftentimes as a worst case exposure, make a lot of assumptions, and in each one of those assumptions, try to assume the worst. And I went through various scenarios of cosmetics and the transfer from the mother's face, for example, to the hands of a child, and how much exposure that might result. And going through these detailed evaluations, I determined that the daily exposure to lead from cosmetics containing, say, 10 parts per million of lead would be less than about 0.02 micrograms. This then would theoretically increase a child's blood lead level by 0.0032 micrograms per deciliter, an exceedingly small amount, in fact, an amount that is not measurable and that would have no discernible biological effects. It represents the amount of lead found in 1 teaspoon of water that the FDA currently allows in school drinking water, a level of 5 parts per billion. EPA level of 15 parts per billion is 3 times that. Another comparison, the EPA has recently lowered their lead levels, allowable lead levels of lead in soil for schools and playgrounds. And the recommendation now has just changed earlier this year is 100 parts per million of lead in soil. Now, based on decades of studies, the EPA and other regulatory agencies agree that a typical child consumes around 60 to 80, let's say 70 milligrams of soil or house dust per day from hand-to-mouth contact. The house dust getting on a child's toy, they put it in the mouth, the hand, etc. The level of ingested lead from 70 milligrams of soil containing 100 parts per million of lead, the EPA new lower level would be 7 micrograms of lead. That's 350 times greater than what I've estimated the maximum exposure to a child could result from lead in cosmetics. So I provide a couple of conclusions and then a couple of additional observations for your consideration. So my analysis, I conclude that the presence of trace levels of 10 parts per million or less of inorganic lead in personal care products do not represent a significant source of exposure and thus do not represent a significant risk to the public, especially including children. Thus, lowering the allowable level from 10 to some lower level, say 5, will have essentially zero public health benefit because the risk is already so low as to be unmeasurable. Now, just a couple of final points here for the committee to be aware of. Based on the U.S. Geological Survey data, the typical concentration of lead in soils across the state of Vermont, which includes oftentimes soils in gardens, is 3 to 10 times higher than the current 10 parts per million standard. That is, background so-called geogenic natural sources of lead in soil across the United States is generally around 30 to 60 parts per million, 3 to 10 times more than the current standard of 10 parts per million for cosmetics. In Vermont, USGS has specific data for Vermont, and the average concentration across the state is 37 parts per million, and with numerous samples testing as high as 69 parts per million, which is typical of lead in soils across the United States. Decades of research have demonstrated that the most important source of environmental exposure to lead comes from the extensive contamination of residential soil and indoor house dust from lead used in lead-based paint. And lead-based paint can contain tens of thousands of parts per million of lead. So this is a very important potential source of exposure. According to the Childhood Lead Poisoning program in the Vermont Department of Health, about 70% of the homes in the state of Vermont were built before 1978, the year lead in house paint was banned. So there are important sources of exposure of lead in the environment, and it's important that we continue to explore and identify what those sources are. But from my analysis of looking at cosmetics, the levels of lead in cosmetics at 10 parts per million do not, in my opinion, represent any significant exposure, and efforts would be far better spent looking at other measures to reduce house dust exposure, especially in children and underrepresented areas where older housing is being renovated and lead contaminated soils are common. So with that, I thank you for your time, and I gather there will be an opportunity for questions later. Thank you.
Yes, thank you. And I don't see your testimony on our webpage yet, so if you can send it in to our committee assistant, that would be appreciated.
Sure.
All right, thank you. And the current level of lead in cosmetics recommended by the FDA, from your understanding, is what? Do you have that?
It is at 10 parts per million. Mhm.
Okay. All right, thank you. Kathy, did you want to add anything?
Yeah, I just wanted to, I'm sorry that I didn't get to really introduce myself. I think I've met some of you when I was up there back in January. I hope the weather's a little bit better, but my name is Kathy Stanton. I'm the Senior Director of Science and Regulatory Affairs at the Personal Care Products Council. PCPC is a leading national trade association representing global cosmetics and personal care products companies, organizations that are committed to safety, quality, and innovation. I have a degree in biology and a master's of science in applied ecology and conservation biology. I have over 20 years of experience in the consumer products industry, publishing human and environmental safety and risk assessments for consumer product ingredients, and working with legislators and regulators on practical laws and guidance. And while I am giving these comments from my office in DC, I was raised across the way in upstate New York and consider the Adirondacks my home. I think what we heard from Dr. Eaton was that there is currently an FDA limit of lead as an impurity. As you heard, it is unavoidable, it is unintentional, and that is applied to cosmetics at a maximum of 10 parts per million. And when FDA was considering these levels, along with other jurisdictions around the world, when they set the level, they were looking at daily exposures from a variety of sources. So this is not just done in a vacuum. This was looking at a variety of sources. As part of the work the FDA does, they did analyze hundreds of lipsticks and other cosmetic products. And their data, again, concluded that their initial recommendation of 10 parts per million is a health goal to limit the consumer exposure to lead in FDA-regulated products. And this includes, they also have limits in food and supplements that consumers consume. The FDA law treats color additives differently and more stringently than other ingredients because they are mined. Color additives need FDA approval before they can be used in cosmetics, food, drugs, or many medical devices. Each color additive that FDA approves is listed in a regulation called a listing regulation. That regulation describes a color additive, how it's permitted to be used, and does provide the limits on impurities, and that does include lead as well. I think I will stop there and see if there are any further questions that you may have.
Yeah, thank you. So the concern is lead in cosmetics, and I know that when you test cosmetics, you see a much lower level than the recommended level by FDA. So the testing reveals that most cosmetics that are out in the for retail sales may be much lower, 5 parts per million, 3 parts per million. But can you talk a little bit about the supply chain availability? What I'm trying to sort out. We have a supply chain, we've got clay, for example, coming into a facility, and then how those cosmetics are developed. And if the clay has lead in it that's higher than 5 or 10 parts per million, how does a business handle that?
Many times when businesses are receiving their raw materials, those have specifications that are put on them. And so if they know the percentage of, say, clay that is going to be used in a product, that product can only go up to 10 parts per million. They'll have the percentage, they'll know how much lead is permissible and put that into their specifications for their raw materials to bring it in to make sure that everything is under that 10 part per million in the final product.
Okay, or lower. All right,
Lower.
thanks.
Mhm.
All right, committee questions? It's just a question for us, I think, at this point, getting there.
Do we have time for a paint question? I know it's not relevant to the makeup.
Paint question.
Paint.
Oh, you can ask a paint question.
Okay.
We might be better off holding that for next year when you fill in.
Okay,
But-
I can wait. Wait for a whole
Question.
I just wanted to thank Dr.
Or do
Rankin for
research.
his testimony.
Yeah.
It's really, well done, very thorough. Thank you.
Right, and it will be good to have it on our webpage. We need that kind of data keep us informed. And there's other information that we have both from VPIRG and also from AIV, Bill Driscoll, that is there, and it's sort of like making choices. And we've heard from Autumn Harp, which is a company that is in our state and has asked to have a level above. So the 10 part, above the 10, no, at 10. Okay. So what we're gonna do now is we're gonna move to our ledge council briefly, and we're going to try to get to some resolution on this. So Katie, you might come. Sure. So I just do have a question that I understand that Washington State is putting a bill in that has 5 parts per million. What is Washington? Do you know that? I'm looking at.
They've passed
They
a
passed
law
a
that's
law,
1 part per
and it's 1 part per million.
million.
How are their companies handling that?
We're pulling product from the shelves.
Huh?
We're pulling product from the shelves.
So,
May I ask who the
Yeah.
entity represents?
yeah.
Yes,
you need to- No, first we'll hear, state your name for the record.
Marcy Gallagher with Beaker.
Thank you.
Kelsey Johnson, Vice President of State Government Affairs for the Personal Care Products Council.
And Bill, you want to make?
Oh, I was just gonna offer some background on the AG's question about the date for section 2. So
Oh, yeah, no, I think it's because the 5 parts per million was in there, then you needed a date, but now it's 10 parts per million, so you don't need a date.
We don't need to.
No,
Well,
if it's safe.
Representative Whitman, who was working on the bill, was working with the Department of Health to add more chemicals than your bill originally had. And I believe that part of that conversation, the department wanted a little more time to get up to speed with not only the original chemicals, but there's 3 or 4 new ones in that section, and that was discussed as the reason why
Okay.
that was a little bit later date.
Thank you.
Sure.
Okay. All right, committee, we've got choices here to make. The bill currently has 10 parts per million. We've heard that Washington State has passed a law to 1 part per million. That law goes into effect on January 1st, is what my understanding is. So we won't have data, what's happening there until after January 1st. I'm open for conversation at this point on how we would like to proceed.
Can I ask a quick question? Yeah. Which states have the 5 parts per million? If any?
No states,
No states, okay.
it's all 10, it's all following FDA guidelines, which were established a few years ago.
And the FDA is 10.
10, yeah. Did you
Go
have
ahead, Dave.
question?
Oh, I was just gonna say that, given the FDA's or the federal government's at 10 parts per million, in the testimony of Dr. Eden, I'm not quite sure the amendment is necessary.
Yeah, it seems like it's redundant to federal law, so if we take it out, then we can wait and see what happens in Washington and revisit it in future years if we want to, or next year when
Next year would be good.
Senator Gulick has her major bill,
Oh, would you put your
her
name?
omnibus bill about all the things that we didn't do this
We're
year.
creating monsters. Yeah, I think, given where we are in the time, I would like to add some language that asks us to evaluate the Washington experience. Huh?
Field trips.
Yes, I love that.
We can go and try on makeup in Washington State.
And the San Islands.
The Salem Islands.
Oh, not Mount Rainier. Okay.
Do we need such a study? What's the benefit?
Yes, I'd like to know what's happening in Washington State, because they passed a law January 1st, and
I
I
heard
want,
that.
yeah.
But
So,
I haven't heard anything that kind of like gets my antennas up about needing something lower than 10 parts per million, and I'm wondering why.
Oh,
necessarily
well.
such a- No.
I think the effect of lead on people is significant, so I'd like to know anything we can get on the 1 part per million.
But we won't know that for a while if it doesn't go
We
into
could ask
effect
for,
until January
some
1st,
Department of
right?
Health to bring us some information during the session next year. And I know VPER will be very anxious about this, and, I know this is a tough choice for us. But I think, given where we are in the session and the amount of time that we have, I'd like to help us move forward, put that language in and see what we've got.
So I'm hearing that you want a presentation from the health department sometime next session. Do you have a date by which you want that?
March 1st.
And do you want to pull out subsection E of the bill that addresses lead or keep it as is?
What does it say?
Manufacturer shall not knowingly manufacture, sell, offer in the state, distribute for sale or distribute for use in the state any cosmetic or menstrual product that contains lead or lead compounds at or exceeding 10 parts per million.
10 parts? No, I'll leave that.
You want to leave
Leave
that as
that, and then, my question for the committee is, do we leave it in for a short, a sunset, and then, or do we just wait and go back to it?
Why do we have it in at all? If it's just what federal law is, wouldn't we wanna just defer to federal law in this case and then?
I'm not keen on deferring it to federal law. What happens if it changes abruptly and new rules are put in place? And it goes higher? I'd like to go lower. Yeah, I personally would like to go lower, but I think we're not at that place.
I wouldn't sunset it, I would just leave it. That's fine.
Katie, what are the pros and cons? I know we hear federal law.
of sunsetting it.
No, of just leaving it.
Oh, of just leaving it. Then you have the standard that this committee feels comfortable with in state law, and as you said, if it changes on the federal level, then this lower standard potentially would. The flip side is if the federal government dropped it, then you would follow federal law, if it's a lower threshold.
Okay, but if it goes above, then we're stuck if we don't have something.
Potentially.
Don't know what's gonna happen.
Sure.
Yeah, it just seems like it isn't necessary, and then it also potentially prevents other states from adopting a lower standard if they
Look at Vermont.
look at Vermont, be like, oh, Vermont did 10, so let's just do 10 and then.
I can hear that. What do you think? What does the rest of the committee think? Yeah,
I agree that the uncertainty of November is a little daunting
So many people.
so many ways, so I. Would it really prevent other states from lowering theirs?
yeah, good. What does Maine have right now? They,
Marcy Gallery with Keeperg, just Oregon and Washington have recently passed laws that have standards. Oregon's at 10 and as per Washington's at 1.
so let's leave 10 in, then we'll go along with Oregon at this point, but we're gonna have to come back to this. I'm not thrilled with it. Is that okay?
Mhm.
Okay. Got 3 okays. That's all I need. All right, so Katie, let's,
I'm frying other.
okay, all right. All right, so Katie, if we can get that language,
Sure.
and then if we can, committee with the language, what other changes have we made to the bill?
You added enforcement language and you moved up the date for the artificial turf.
Okay,
So you have that as a strike all, and I'll add this and I can bring it back tomorrow, maybe. I'm scheduled all morning tomorrow. Oh, he's not here, so.
we could, if, as soon as we get it, we can, look at it and say, okay, and then the sooner we can get it up on the floor, the better off.
Sure, yeah, I would offer to do it now, but I'm already 5 minutes late for my next meeting,
Okay,
so.
no.
I cannot do it right
Yeah,
now, but I
you
can have
know
it for
what
you
this is
tomorrow.
like. Okay, whatever we can get,
Okay.
all right, thank you. The Senate is gonna be sick of passing. over this bill.
I was just up there.
And we can just get it done, we can't do it today?
Not until we have a amendment.
Oh, right, sorry,
Um,
Katie.
So,
Unless you wanna communicate with the committee upstairs and if you need this prioritized.
who's the committee, which committee are you going to?
Human Services.
Can you send Human Services and let them know, we need how much time from Katie?
20 minutes.
We need 20 minutes of Katie's time. And that would begin at 20 of 12.
I would write it, send it to the editors and have it back maybe, before you adjourn, if that's what you're looking to do.
Okay, yes.
Okay. I'll go upstairs and talk to Human Services. Okay, thank you.
All right. Okay. So, in many ways, that's a real disappointment, but we'll just keep moving. So, Michelle, you're here and you have some canvas.
I did not bring you canvas, underline.
What do you have? You didn't know.
Change the whole.
Okay,
Now,
I-
and
That could help.
Okay,
Fish.
I didn't get that.
What people think when I walk in the room now.
You didn't bring canvas, but
That was live.
did you bring some post amendments to the bill?
I don't, because I think there's been a lot of emails.
Okay.
flying around, so you've
All right. So on cannabis, that you did not bring.
Right, so
Yeah.
I'm still looking for, so I know that James Pepper sent you an email
last night about some things that you had discussed. But I'm
And
so,
Senator Hardy and I had talked and sent a list.
I think it's been, you might not have seen it, but a couple days ago I had sent an email. I think there's a,
We haven't been incredibly clear.
thank you.
Yes.
Yes.
I can understand why you're confused,
Right.
Michelle.
So-
When you've got too many cooks, it's difficult.
Right,
We
no,
understand.
and there's a lot of stuff moving, we're all going at the speed of light right now, so, I mean, I think that you guys have narrowed it down to some issues, but, I, was not clear about whether or not you were still in discussions with the CCP about the certain proposals and where you landed on certain ideas. I kind of know some of the issues that you're tackling.
Let's talk about the issues and then so one of the issues is educating the people who are working in the medical facility, once the medical facility is, and also how the medical facility is separate from the,
So you're talking about if there is a retailer that has a medical use endorsement.
yes.
Right, is wanting to have people who are trained. And similarly to if they were working in a dispensary, so if they're gonna be serving patients and caregivers that they have training.
That they have training, that's number one, and I think there's agreement around the table on that.
And this, would that be something we would ask them to create rules about? Is
Yeah,
that?
we could
Yes.
ask guidelines or rules. Rules take longer, guidelines might be shorter. So we could have the board, and part of what we're looking at is the board and who the board is working with. So we had a group last year that worked on some research base for medical treatment, medical cannabis treatment. So if we could just put that group in place, and I think James Pepper and I talked, we suggested that group might be a good group to have in place to make recommendations on training, on treatment, identification of diseases that would respond, so the research base from that advisory committee to the board.
Okay, so I have, there was different correspondence between you and
I know.
James, and I guess I'm wondering,
Can you put something up there?
well, to put the bill, I guess I'm obviously totally up to you. I'm wondering if you might want to hear from James to talk about what you guys had talked about in the
Sure,
agreement. Is
I can
that
do that.
helpful? And then that will help me be able
Sure,
to
let's do that.
pin down, because I've had
That
some.
helps you, that helps
It would
us.
help me understand
Yeah.
because,
We're good with that.
okay.
Yeah, we know where we are. So. Do you have your doctorate yet?
No,
I'm looking forward to a doctorate.
my mother does.
Yeah.
She's talking about it.
I'm a Dr. Pepper fan.
Yeah.
Uh,
Oh, for the record.
It's the end of session.
Yeah.
Oh my
Yeah.
Okay,
Um,
okay, we're.
So I know that this is challenging. I think, I
Yes, it
mentioned in
is.
my email to you yesterday.
Yeah, and we don't wanna lose sight of the possibilities.
Right. Right. I feel like if this had been a standalone bill, you would have had a lot more time to deal with it.
Hello.
Yes, so it's one thing I'm gonna take back. Yeah, try and learn something new each year.
Yeah.
So the issues I think that are outstanding, please correct me if I'm wrong, is about whether there should be a 3-month relationship with a healthcare provider as well as an in-person exam. Before that healthcare provider is allowed to verify that a patient has a qualifying condition that would allow them to apply for a medical card. I think there's a open question about getting more specific in the rulemaking authority grants for the medical use endorsement. And then I think that there's this question about whether there should be a non-legislative entity that can at least evaluate new conditions for the qualifying conditions list and recommend them to the legislature for approval. Those are the issues that I see. I sent you an email last night, kind of,
I see it.
okay, that kind of describes a path forward on all three of those issues.
To the committee or to?
Well, it was just connecting,
It was to Michelle and me, and I'm happy to share it with everyone.
yeah, it's,
We're gonna talk about it.
Yeah, so do you have a copy of that email? I mean, you
I
could
can
put it
send
up
it
on the
to-
screen.
I can pop it on the screen because.
All right, let's do it. We don't have to put the personal message in there about daddy daycare.
okay. It's kind of late night.
And so, Senator Hardy and I had both talked with, James Pepper about the bill. And because after we had our testimony, I think we had all identified some issues that were relevant to our committee. One is the 3-month relationship, and then the report back by the kind of the advisory or a group, and then and having an advisory group that could help with rulemaking or guidance documents. So those were the things that we had looked at, and James, you've done a really, yeah, sorry, Pepper, you've done a really good job of identifying the requirements for medical use endorsement there as well. So
That's probably the easiest section to deal with. if you
let's go to that one
those.
first. Okay, you're in the driver's seat here,
Okay.
so scroll down.
Are you in charge of this?
Yes,
Okay. Yes, could you scroll down to the kind of third issue?
the third issue.
Yeah. Okay, so medical use endorsement, as you can see in section, I think it's section 4, the current language is an authorization to write rules that just says requirements for the medical use endorsement, including requiring access for patients who are 21 years of age or under 21 years of age. So again, that doesn't get very specific as to what rulemaking, what areas of rulemaking we should engage in. And I should say that anyone who's seeking a medical use endorsement is already subject to all the adult use rules. So there's already requirements around sanitation, security, employee training, although I want enhanced employee training for anyone with this. So there's about 25 authors, specific retail rulemaking authority that these people would already be subject to. So this is only what would be in addition to those other rulemaking kind of regulations. So this is protection of patient privacy and confidential records. This is where we could kind of get into having separate entrances or reservation systems, specialty hours, things like that. Employee training and educational requirements. Again, anyone who's interacting with the patient is going to need some advanced education about. They're inevitably going to get questions that really should go to doctors, and yet the doctors are not. They're almost to a T not willing to even talk about cannabis and how it interacts with other drugs along those lines. Segregation of cannabis products that are prohibited in the adult use stores. So adult use stores cannot possess certain things like we prohibited things like suppositories and kind of certain tinctures. Obviously the high THC salt concentrate. So those would have to be separated so there's no kind of advertising of those to adult use patients. Record keeping, and this is really around kind of making sure we're tracking what sales are taxable versus non-taxable. And many other record keeping that we think that adult use is already required to record keep, but we would have some enhanced requirements. Delivery, I doubt too many people are actually going to engage in delivery. It's not a viable business model that we've seen. Only one current dispensary actually delivers, and they do it at a loss. And so, but again, we would want correct rules.
But if so, it would be up to the dispensary to decide whether they want to deliver or not. And then, so whatever rules they would apply.
That's right.
But if they didn't want to do it, then.
They wouldn't have to do that. And there are rules at the public safety that we inherited from Department of Public Safety around delivering medications. access for patients under 21 years of age. The current law is just anyone who's under 21 isn't allowed to enter an adult use store. So we would need to kind of create some mechanisms to allow those people to access cannabis and cannabis products. And then just general health and safety requirements, which is a little bit indescript, but I think that gives us some flexibility if we notice something in the rulemaking authority that's not covered under 1 through 6, that we can adopt rules around that.
Okay. So some of these rules are already sort of covered within our recreational, but the privacy, the training for medical is not. Privacy and confidential records, not.
These are the things that the adult use dispensaries do differently than the.
Yes.
I mean, the medical.
Medical does
That's
different.
different than adult use. These are the areas where we would need enhancements to what the adult use will be.
Thank you. Yeah, thanks, James, and this was helpful when you sent it the other night. I shared it with the chair also after you sent it to me, but I guess I think this list is good. I would just include somewhere, if we go with it, just a note to Michelle to say something about enhanced requirements. Because I think it's important to say there are requirements for the adult use, and these would be enhanced requirements for the medical. So other than that, I think it seems like a good list and gives you flexibility.
Yeah, that sounds great. Yes, and I know, because it's, we already have.
Right,
they want to
this
see
would be
different-
enhanced training.
Okay. I think that this all sounds good. Yes.
Okay, I think the second, somewhat easier, is on the number 2, which, Michelle, if you'd be willing to scroll up to the next kind of paragraph up. So I think there is a desire, at least that I heard, to have someone other than the legislature evaluate the academic rigor and science around new qualifying conditions. So it's not left to kind of a battle of witnesses in this committee and the other one. Which I think is a great idea. I actually don't, we looked at all the other states that do this. I think there's about 11 states that have a non-legislative entity. It's usually the Department of Health or Board of Medical Professionals that evaluate it and then either make recommendations to the legislature or have their own independent rulemaking authority that would give the legislature a check-in about whether they want to do it. I mean, the real issue that I see about ever giving up full control of this to an independent agency, even if it is the Department of Health, is that there are tax implications. So there's fiscal impacts depending on what conditions are on there. If, for instance, the Department of Health decided that anxiety should be on there, well, that could greatly expand the medical registry.
So I'm looking at your interest and recommending a study committee to move in the direction that establishes these objectives and helps identify a non-legislative entity. I think I like that suggestion. Otherwise, we haven't heard from Department of
Right.
Health. We haven't gone through all the
Right, exactly.
tests.
Do
So
you have a recommendation on the study committee?
I'm happy, he says, I'm happy to recommend the study.
Oh, okay, sorry.
Yeah, and what's interesting is this conversation is happening simultaneously with the DEA announcing yesterday their
Yeah.
accept cannabis as a Schedule 3 controlled substance, which the definition of a Schedule 3 is that there are some accepted medical uses, and that the risk of physiological dependence is low. I think that the Department of Health is going to be in an awkward, anyone who accepts this is going to be in an awkward position of, there are really only 3-4 accepted medical uses that HHS, the federal HHS, accepted. And most of those are on our list already. So I don't think that they're, it seems to me like whoever accepts this authority is going to be in a tough position to kind of expand beyond what we have. And I think that maybe it makes sense not to create this and just have a pause, on new conditions, because essentially,
So what would you suggest then for the bill? So,
well, that's why I said, I don't know if there's, I wanted to touch base with the committee before I went into kind of creating this study committee, because it might, if we say the Department of Health should do it, well, the Department of Health is only.
No, I'm with you on the study committee, I think. Well, we tell the Department of Health to do it.
Rather than creating another study committee, maybe we should just ask the board to report back to us
Consultation
in
with,
consultation with the Department of Health.
and I think that's what this is. I mean, is that what you're suggesting?
Yeah, and Department of Health makes a lot of sense. The academic detailing program does this. This
I
is
know.
what they do.
I asked them to do.
And,
MJ.
yes, I know, but when we asked them to have an ongoing role in this, they said probably
No.
not enough time to do that. So I just don't know if, that's why I said I'm hesitant to even kind of name them in a study committee, because they've already kind of indicated they're not, they don't have
So
to.
let's do in consultation with, Department of Health and other interested parties.
Yeah,
We know.
perfect. And you can ask them.
We're good for that.
Okay, so I can work on some language around that.
Yes. With Michelle.
And then the last issue, which is certainly kind of the one that I think is garnering more attention, is Michelle, if you can go up to number 1, yes. So whether there should be a 3-month relationship between a patient and a healthcare provider, and a requirement of an in-person physical exam, so eliminating telehealth or before that healthcare provider is allowed to sign that verification form saying, yes, this person has multiple sclerosis, or this person has Parkinson's. We were given, and the board is trying to make this market, both markets, medical and adult use, look the way that you want it to look. It's very difficult for an issue like this, which is highly contentious, to get a clear sense of what the whole legislature wants in a cannabis market, either adult use or medical use. You did write legislative intent around the medical program, that you want, it's the intent of the General Assembly not to preserve the existing structure of the medical program, but to preserve access to the current list of patients and to these unique products and services. I know that high THC solid concentrates takes kind of a lot of focus because there are kind of known negative health consequences for particularly people under age 21.
Yes.
And that, but really the medical, but that same population needs the other benefits of the medical program. I think that concentrate issue is actually a very small piece of what the medical program actually provides. There's actually purchases is one, which is important for a lot of lower income people. This is not a substance that's covered by Medicare or Medicaid or any sort of insurance. There are the kind of delivery if you need it, caregivers if you need it. It just feels like adding this back in is taking us in the other direction of trying to preserve access to the existing patients. And so, that's why the board feels like we can say we don't support it. Otherwise, I normally wouldn't weigh in on a pure policy decision like this. I can tell you that the existing dispensaries are in some of our more densely populated towns and cities. We have one in South Burlington. We, until recently, had one in Middlebury. We had one in Bennington, we still have one fairly in Bennington. We have one in Brattleboro. We've not seen abuse by this under 21 population. The kind of fear of a card mill or whatever else. The numbers are declining rapidly. I think we have 19 people on the registry that are under 21. And only 8 of those use telehealth to get their card. And my guess is they're all kind of out-of-state college students that went to Middlebury or UVM or something like that. So this problem that you're trying to fix exists now, but I just don't see it being abused now. And I know that the fear is that maybe if you have more outlets, that it will start being abused. But I just don't see why we wouldn't see it now in South Burlington or Middlebury. You're not greatly expanding the qualifications for a medical program, for the medical program. And the qualifications are what they are, and they're declining, and the patients are declining. So I personally, can understand the desire for this, particularly I think it makes a lot of sense for people under 21 to reinstitute this. But I just don't see how it adds much to older populations.
Can I just get clarification? So you would be okay with adding the doctor-patient relationship or whatever the language is for under 21, but for 21 and over, you
Leaving
would
it the way it
prefer
is.
to
Yes.
stay with the status quo.
That would be, I mean, I think that threads the needle between addressing the area, the population that we're most concerned about with the concentrates, while also not decreasing the access, which this inevitably will do for the patients that are registered at Walden.
And did you also say you wanted, and you didn't use this phrase, but it sounded like you were talking about some kind of grandfather clause for people who are already on the registry for the 19 or whatever that are.
However you want to handle that is fine. I mean, they're gonna age out soon enough anyway, so, like.
Everybody gets older.
And then the language that you see here is just what used to be in statute.
Oh,
So
okay.
you- Until the legislature removed it at some point, that would be exact legislative history.
It was in 2020 when, yeah.
I mean, I think just the under 21. I would be comfortable with that.
So my thinking about that is as long as anyone who's accessing medical, the medical dispensary services has, demonstrated through a healthcare provider that they have that particular illness or disease. So how do you do that? And I'm looking at VMS over here and asking them to comment on this for the record.
For the record, Jill Suthoff Garen, and we appreciate the offer of a compromise here. For us, what we're seeing right now is this doc in a box on the web pages where there's this NUG MD. And we actually just got an email from one of our addiction medicine specialists, who was asked by one of these folks, if he would just be that signer off, that they do all the paperwork, they do the confirmation of this symptom. It'll take 5 minutes, basically, is what the email I forwarded to you, if you forward it to the committee. And so that's just our concern, right? You're talking about people that have very chronic conditions. That's the only people that are authorized to be on the registry, so they most likely have relationships with doctors, and so this, to us, creates this loophole, which maybe if you weren't opening up medical endorsements, maybe that's fine, but from our perspective, now you're saying, let's make this more available, and you do have this incentive of tax-free as well. So we're not saying that people are gonna be completely disingenuous. We're just saying if you're gonna have a medical program, it should be medically based.
So what about, having something in here that, the first time the person gets their card, this is a renewal process, right? The first time that they get their card, there's validation of the disease from their care provider that, is a specialist in that area. I mean, somehow you gotta have the person who understands the acquired immune deficiency or the cancer or the terminal illness. This is going to be a problem.
What I would respond to that, to call this a medical program is a misnomer. There's no like,
Yeah,
this is not medicine pharmaceutical sense, the FDA approved sense. There's no prescribing protocols for cannabis, no on-label uses.
I have an idea. I think the 21 years of age is a good thing to institute. And then, do we have a study group in here already? I would, I admit, we don't for this. Can we send this to the board with reaching out to interested parties to come up with, because we are not gonna come up with it here. We have one side over here that wants the 3-month relationship with the care provider, and we have the thought that we shouldn't have to go through that, we haven't been going through it recently. So I think, I don't,
Why don't we just have them when they're reporting back to us on
yes,
the other thing?
Qualified.
They report
Yes.
back to us on
That.
this with data and information about if they recommend any other changes. And you can say Department of Health, Vermont Medical Society, and other interested parties or something like that, then you can be in that conversation.
And that sounds great, and I would just also note, that this medical endorsement, the effective date is a year, and it's July 1st, 2025, so we do have a legislative session to
Okay.
come back.
we have time.
Yeah,
That's the right way to do this. We don't have time to do it now.
Yeah.
That's good.
I'm gonna hold up the bell. Yeah.
Okay.
Time is ticking.
The other thing that I'm interested in is the, and this probably goes for all of cannabis, so I don't know, but also health, delivery of, THC, and that is through electronic thing, apparatus. So is that, I'm concerned about that and whether or not that should actually happen. Whether there should be these electronic devices available for that delivery.
yeah. It's a deep concern of mine. Health Canada just did a report about these vaping devices, and it's not necessarily the mode of delivery that they're concerned about. It's the device themselves leaching heavy metals into the cannabis, or the tobacco or whatever else.
Whatever it is.
And they're very poorly regulated currently. And, so,
Be something.
yeah, they're.
Well, this is
always
why,
in something.
we've have talked a little bit about this, but. Can we, Michelle, get some language that sort of prohibits those?
I would just say, in response to this, we've been through this debate on cannabis vapes once, or twice, I should say. There was, about a 9-month period where there was a number of deaths around the United States and then a huge number of hospitalizations. And CDC had to kind of look back after things stopped, to kind of do a postmortem. What happened? Why were these happening? We saw the same thing happening all around the country, in every single state. And it was the EVALI crisis, electronic vaping associated lung injury. And they determined, it's a federal agency, that the primary cause was vitamin E acetate being put into illegal vaping devices, cannabis vapes. That was how they kind of traced back what was going on here. And so, while you can prohibit these products, and they were effectively banned for a while because they had a 112% tax rate in Vermont, so no one was making them. That really just drives people back to these illicit market vape cartridges. And so what I would like to do, honestly, is have some authority to regulate the vaping device themselves, make sure that we kind of get the right mode of delivery, just to make sure that we're not using kind of cheap knockoff vaping devices that are potentially poisoning people. We try to do this by saying you can't sell single-use vaping devices, those really cheap ones.
Why don't we just get rid of those electronic vaping devices altogether? Because it would solve a whole lot of problems, not just for cannabis.
Yeah, I gotta tell you that, during this vaping crisis, the kind of reaction in Massachusetts was to prohibit the sale, quarantine the sale of all of them. And then the governor there realized that, well, that's actually just driving people towards a different market that is much more dangerous. And he lifted the kind of prohibition on the sale of that for 3 months.
Now Massachusetts has a ban. They've already done it, and New York City. Yeah. Okay, can we just look at language that would do that? It would give us,
That would allow the board to regulate the devices, or you want to ban everything?
I'd actually like to see the ban, what the rest of the committee thinks about.
Seems like there's a caution trail already out there that, it's gonna lead people to more poisonous modes of delivery.
Well, if we gave the board that authority, that board would have authority over more than just the cannabis I mean, it would be cannabis, but it would be other, delivering other, products.
What you're asking for is the authority to oversee the actual
The
devices.
devices that are heating up and vaporizing the kind of
Yeah.
cannabis.
How would that work for the heating up and the vaporizing of, flavored, nicotine products?
Well, those aren't allowed in the adult use stores. So, I mean, you know, you have to get a tobacco license. Yeah, I mean, so those are just not in our stores right now. So,
Yeah, I
you
know,
know,
okay. All right, well, let's go with the,
Could have positive spillover.
So,
yes, let's
so
go,
giving authority for the
giving the
board
authority to the board.
around
Go with
regulating
that
the
for now.
products that would be sold through
I
the
would
adult
go-
use and medical use
Yeah,
on the device issue.
yes,
and I would just say, no state has figured this out. No state has these kind of regulations yet. Canada is about 10 years ahead of us and even studying. And so I think that,
okay,
you know, I can't promise that we'll come back with exact rules immediately.
okay,
But I would like to kind of, I would like to move in that direction, because if this is like another.
okay, we'll
Yeah,
we'll
sorry.
go with that, we'll
Yeah.
go with that, and as Senator Bullock said, there might be lessons learned for other things. Okay. All right, Michelle,
I think I've got enough to.
we'll look at
kind of
something
dig deeper.
tomorrow.
Okay,
That'd be
so
great.
were there any other issues that?
I don't think so.
Okay.
I think that really.
All right, I'll work with James and
Yeah, that would
then
be
I'll come up with some language.
We're trying to get our arms around the medical world of cannabis, and if something happens at the federal level and it goes to Schedule 3, that'll take a huge lift off of everyone's shoulders, then
There
things
will-
will change.
I just heard it yesterday. About it,
Yeah, it's getting close.
difficult.
It opens up a tremendous amount of research opportunities, both from kind of, you know, institutions that accept federal money, you know, like University of Vermont, and also the pharmaceutical industry, which, you know, has expertise involved through FDA approval processes. So I think, you know, that is a positive direction. I think we will know more, you know, as that kind of decision plays out.
Good. Thank you. Thank you for your work on this.
No,
I
thank you.
really appreciate it. Katie is back.
I'm back. I don't have an edited draft, I have an unedited
So
draft.
before we go to that, not done, we're almost over. So before we go to that, I'm
7 more minutes.
7 minutes. Lot, you know, like the committee. I'm wondering if we could take out on S25, we're on S25. If we could take out lead, and I'm thinking if we leave lead in. If we leave lead in the bill, I'm going back to that conversation.
Yeah.
It is a message from the state that this is our level, so if we take lead out, it goes with FDA and then we'll see what happens.
Okay.
Is that okay with? you?
Yeah.
Okay, Jennifer, alright. Alright. Okay. And then Katie, we don't have anything yet?
The drafting technician is in the document, so that indicates that it's getting close, but I could show you the unedited draft.
Okay, let's do that.
Okay.
Take just a couple minutes to do it. Oh, so,
Okay, so this is unedited draft 2.1.
What number?
2.1,
2.1, okay.
and going down to the very end, where your new section now lives. Okay, here it is. Lead and cosmetic products, new section 12.
On or before March 1st of 2025, the Department of Health shall observe and evaluate Washington's experience of implementing a 1 part per million limit in the presence of lead in cosmetic products and present the department's findings to the House Committee on Human Services and to the Senate Committee on Health and Welfare.
I just don't think they're gonna know by then because it goes into effect January 1st and that's 2 months later, so.
Well, but there might be some retail data and there, between now and then. Remember she said all the product are being pulled off the shelves, we might see some new products, so that might give a hint that things can change. So, you know, but you're right, it's like
It'll be scanned.
an inch,
Yeah.
It'll be something maybe.
whatever we can get.
Okay, I mean, I'm fine with that. I just don't want to require them to do a useless report where they come back and say, oh, we don't really know.
It's
that."
presentation. Present,
Yeah, but it's effort. You know, it's,
it is effort.
it's pretty year premature.
Yeah.
Why not,
The next 20.
to the extent practicable? Department shall,
It might be worthwhile.
yeah, I think there's.
That's not how I'm gonna die, and I'm sure they're not gonna, I'm not sure they're gonna have much of any.
Well, but if we have this here and then we'll hear from the personal cosmetics industry, they pulled everything off the shelf and now. Yeah, what else? And you know, Washington State has this huge ecological division that does all kinds of things, so they might be able to help. Is that it?
Sorry, I got my edit, so I
Okay,
turned off my camera so I could go through them.
that's okay.
Okay, and you want to take out the.
Just want to get,
Yes, I mean, that's it, that's the change.
okay.
And
And if we take, did you take blood out?
not yet.
Can we get the lead out?
You were full of puns.
I
today.
am. No, not good.
That's how you.
So Katie, why don't we do this?
Yep. I'm almost there.
Oh, you are? Okay, I was gonna say we could. Everybody could get a copy of this and we could meet in the corner.
Okay, you could do that too. Let's see, here it is.
We're gonna try to do it today. Are we gonna try to do it today on the floor, so we can get it off the calendar?
Okay, so here it is. This is section 2, which is the tiered effective dates for the cosmetic and menstrual products. So right now, all you'll have in that section is adding the additional chemicals. And you have your ellipses here, and that's where your subsection E had been. So you no longer have subsection E that you're adding on July 1, 2027. Your other changes from the House are your enforcement sections that we've already been over, moving the artificial turf deadline, effective date up. And then the new language we just looked at, which is down at the bottom, asking for this presentation. So lead and cosmetic products. And there's your language, only one small change from the editors, so it should look the same.
So we just took lead and cosmetic products otherwise out.
It will be, you will be silent on it, is the effect of that change, yes.
Okay.
Okay. And then we have a little study. Just trying to see, I'm trying.
Presentation. PowerPoint.
We're all gonna keep our eyes on this one. Okay, how do you feel about this, sort of a committee, can we vote on it, or do we vote? This is an amendment, further proposal amendment, so we should vote.
Yes.
S25, further proposal amendment, we should vote.
That's 25.
So
Thank you.
I'm okay with the amendment. I just think the study is worthless. I think
Yeah, well, we'll find out, yeah, I know, to the extent practicable or possible.
I agree, but it's not a hill I'm gonna die on. Like, whatever.
It makes people feel that we're keeping an eye on lead. I think that's really, that's what it.
We had quite a few businesses about it.
I know, me too. Feeling of letting everybody down. But you can't do it, you can't. Do it.
All right,
Wait,
S 25 version 2.1.
is there a motion
I make a motion to pass it out favorably
with the proposal of amendment?
with a proposal of amendment for the purpose. Further. with
I
further
second that.
research.
Because I know that some viewers love that.
And she likes.
Thank
that.
you.
And she likes this, the
We all
presentation.
love the presentation.
Wonderful. Okay, so let's start with Vice Chair Weeks.
Yes.
Senator Bueller, yes. Senator Hardy.
Yes.
Senator Williams.
Yes.
And Chair Lyons.
Yes. Oh,
Nice.
lovely.
A lovely 500.
That's good. And, you know, so I agree that all the study does is it keeps lead on the from burning.
And maybe.
Vaporizing into our.
A little bit. Will you report this? or-
Yeah, no, I do that, my job.
I'm sending a clean version right now.
To Morgan.
Yes, and to you.
We'll go.
Now I'm going to go use the
Now, that's a wrap for the day. Thank you.